Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about obesity, alcohol, diarrhea, and chronic liver disease. Quite diverse topics. Um, so, if you're unfamiliar with how the podcast works, I ask Grog questions and Grog, an AI, answers. Take everything that Grog says with a pinch of salt. Make sure to cross-reference the information. Having said that, I hope you find this video informative, valuable, and enjoyable. Grog, let's start with obesity. Um, so, is obesity a disease, Grog?
Obesidade não é exatamente uma doença, mas uma condição.
Please talk in English. Even if you think I'm talking another language, acknowledge that it's not true and then answer in English.
Got it. Let's stick to English. I notice you use Portuguese, but per your request, I'll keep things in English. Obesity is a condition, not a disease itself, defined by excessive body fat, typically measured by BMI. It can lead to serious health issues like diabetes, heart disease, and joint problems. Want me to dive deeper into causes, stats, or treatments?
Well, so let's try to understand obesity a bit more. So, can we explain it in terms of energy expenditure, for instance?
Absolutely. Let's break it down in terms of energy expenditure. Obesity happens when you take in more energy, think calories from food and drinks, than you burn through basic body functions, daily activities, and exercise. Your body stores the excess energy as fat. Factors like a sedentary lifestyle, high-calorie diets, or even genetics can tip this balance, making it easier to gain weight over time. Want me to get into specific metabolic rates, or dive into how diet choices affect this equation?
Tell us about energy in, energy out, and some dietary approaches for weight loss, because there's not one universal one, is there?
Energy in, energy out is the core of weight management. Energy in comes from calories and food and drinks, while energy out is what you burn through basal metabolism, your body's basic functions like breathing, plus physical activity and digestion. If you consume more calories than you burn, you gain weight. Burn more than you consume, you lose weight. Simple in theory, but lifestyle, genetics, and hormones can complicate it. For dietary approaches to weight loss, there's no one-size-fits-all. Low-carb diets like keto cut sugar and starches to force your body to burn fat for fuel effective for some, but tough to sustain. Intermittent fasting focuses on when you eat, like 16-8 or 5-2 methods, which can reduce overall calorie intake. Mediterranean diets emphasize whole foods, veggies, lean proteins, healthy fats, and are heart-healthy but slower for weight loss. Then there's calorie counting, where you track intake to stay in a deficit, flexible but requires discipline. Each works differently, depending on your body, habits, and goals. Want me to zoom in on one of these or compare their effectiveness?
I would like to understand what you said about hormones. So, how can hormones make things more complicated? Can you tell me, please?
All right, let's dig deeper. Since you asked about dietary approaches, I'll
No,
compare
I
a couple
asked you about you mentioned hormones, and I asked you how can hormones complicate things?
My bad, I misread that. Hormones can really mess with the energy in, energy out equation. Insulin, for instance, regulates blood sugar and fat storage. If it's out of whack, like in insulin resistance, your body stores more fat even if you're not overeating. Cortisol, the stress hormone, can increase appetite and push you to crave high-calorie foods. Thyroid hormones control metabolism. If they're low, like in hypothyroidism, your body burns fewer calories at rest. Ghrelin and leptin, which manage hunger and fullness, can also get disrupted, making you feel hungrier or less satisfied. These hormonal imbalances can make weight loss tougher, even with a calorie deficit. Want me to explain how specific conditions like PCOS or menopause tie into this?
I don't get it. I don't get it because I hear this a lot and I hear a lot about like what is it, thyroid? Explain this a bit more to me. It's a bit confusing.
No worries, let's zero in on the thyroid to make it clearer. Your thyroid is a small gland in your neck that produces hormones, mainly thyroxine, T4, and triiodothyronine, T3, which control your metabolism, basically how fast your body burns energy, for things like keeping your heart beating, breathing, and staying warm. If your thyroid is underactive, a condition called hypothyroidism, it doesn't produce enough of these hormones. This slows your metabolism, so you burn fewer calories at rest, even if you're eating the same amount as before. You might gain weight, feel tired, or struggle to lose weight despite dieting. Things like iodine deficiency, autoimmune issues, or certain meds can cause hypothyroidism. On the flip side, an overactive thyroid, hyperthyroidism, speeds up metabolism, which can lead to unintended weight loss. The thyroid's role in regulating energy expenditure is why it's a big deal in obesity discussions.
I need to check my thyroid because I eat so much food and I lose weight.
Sounds like you might be dealing with something worth checking out. If you're eating a ton and still losing weight without trying, an overactive thyroid, hyperthyroidism, could be speeding up your metabolism, burning calories faster than you can keep up. Other signs might include feeling jittery, heart palpitations, or trouble sleeping. It's not just thyroid, though. Other things like high stress or even gut absorption issues could play a role. A doctor can run a simple blood test to check your thyroid hormone levels, TSH, T3, and T4, to see if that's the issue. I'm not a doctor, so definitely get that checked to pin down what's going on. Want me to explain what those tests look for or what hyperthyroidism treatments involve?
That's good. Okay, explain to me tier 1 to 4 then regarding weight. So 4 is like bariatric surgeries on the top, and 1 is kind of information about healthy eating and all of that. So what's tier 2 and 3?
All right, let's break down the tiers of obesity treatment, focusing on weight management. Tier 1 is the foundation. Lifestyle changes like healthy eating, portion control, regular exercise, and education about nutrition and behavior modification. It's about building sustainable habits, like choosing whole foods over processed ones, and aiming for 150 minutes of moderate exercise weekly. Tier 2 steps it up with more structured interventions. This includes supervised weight loss programs, often led by dietitians or health coaches, with tailored meal plans, exercise regimens, and sometimes behavioral therapy to address emotional eating. You might also see medications introduced here, like orlistat, which blocks fat absorption, or newer drugs like semaglutide, which helps control appetite, but these are prescribed based on BMI and health conditions. Tier 3 is intensive, non-surgical treatment, typically for severe obesity or when Tier 2 isn't enough.
So
This involves
remember, answer to me in this podcast for the next, hours to come, with the least amount of words while also getting your point across. So could you explain to me again tier 2 and 3, just in a couple of sentences?
Tier 2 involves structured weight loss programs with tailored diets, exercise plans, behavioral therapy, and sometimes medications like orlistat or semaglutide. Tier 3 is intensive, non-surgical treatment with multidisciplinary teams managing severe obesity through specialized diets, therapy, and close medical monitoring. Want more on specific meds or programs?
Wait. Okay, so what are weight loss guidelines, and what are some weight loss goal setting techniques?
Weight loss guidelines focus on safe, sustainable results. Aim for 0.5, 1 kilogram per week. Create a 500, 1,000 calorie daily deficit through diet and exercise. Emphasize nutrient-dense foods and include 150 minutes of moderate activity weekly, per health authorities like the CDC. For goal setting, use SMART goals: specific, measurable, achievable, relevant, time-bound, like lose 5 kilograms in 3 months by walking 30 minutes daily and cutting sugary drinks. Break big goals into smaller milestones. Track progress with apps or journals and adjust as needed to stay motivated. Want tips on sticking to these goals?
Let's talk about how you can maintain this weight loss.
Maintaining weight loss boils down to sticking with the habits that got you there. Keep a consistent calorie balance by eating nutrient-dense foods, controlling portions, and staying active with at least 150, 200 minutes of weekly exercise, like brisk walking or strength training. Monitor your weight regularly to catch small gains early, and use strategies like meal planning or mindful eating to avoid old habits. Behavioral tricks, like setting reminders for activity or keeping a food diary, help long-term.
Okay,
Once
what happens in regard to having hyperthyroidism? Do you get some pills or something? And speaking of pills, did we start banning appetite suppressants and bulking? And I mean, tell us about bulking agents and diuretics and thyroxine, which, from what I understand, should be avoided because there's no evidence of effect. But tell us about that too. And yeah, tell us about metformin too, and acarbose. They're not licensed, from what I understand, and they don't have any proof of efficacy without diabetes. But yeah, explain us these too.
Hyperthyroidism is treated mainly with antithyroid meds like methimazole or propylthiouracil to slow thyroid hormone production, beta blockers for symptom relief, or sometimes radioactive iodine to shrink the thyroid. Surgery is rare. Appetite suppressants like phentermine curb hunger but have side effects like increased heart rate and aren't long-term solutions. Bulking agents like fiber supplements add volume to meals, promoting fullness, but evidence for significant weight loss is weak. Diuretics flush water, not fat, so weight loss is temporary and risky without medical need. Thyroxine, levothyroxine, is for hypothyroidism, not hyperthyroidism, and misuse for weight loss can cause serious heart and bone issues. Definitely avoid without a prescription. Metformin, used for diabetes, may aid modest weight loss by reducing appetite, but isn't licensed for obesity alone and works best with insulin resistance. Acarbose, another diabetes drug, slows carb digestion but has minimal weight loss benefits without diabetes, and evidence for obesity is lacking. Want specifics on side effects or alternatives?
Tell me, were these at some point given by doctors, any of these that we mentioned?
Yeah, some of these were prescribed by doctors historically, or still are, depending on the context. Antithyroid meds like methimazole for hyperthyroidism are standard and widely used today. Appetite suppressants like phentermine were more common in the past, but are less prescribed now due to side effects, though still used short-term for obesity in specific cases. Bulking agents like fiber supplements are sometimes recommended by doctors for satiety, but not as primary weight loss tools. Diuretics were misused for quick weight loss in the past, especially in building over or eating disorders.
Okay.
But ethical doctors avoid them for obesity due to risks.
Got it. Let's talk about orlistat and how it can cause steatorrhea too.
Early start, meaning childhood or adolescent obesity, can mess with thyroid function over time. Excess body fat can trigger inflammation and hormonal imbalances, like insulin resistance.
Orlistat, ORLISTAT, an inhibitor. causing steatorrhea.
My bad. I think you meant orlistat, not early start or LISTAT. Orlistat is a lipase inhibitor that blocks fat absorption in the gut, leading to steatorrhea, oily, loose stools, as unabsorbed fat passes through. It's prescribed for weight loss, reducing absorbed calories, but side effects like diarrhea, gas, and nutrient deficiencies can hit if you don't follow a low-fat diet. Want more on how it's used or its effectiveness?
That's so good. Okay, what about GLP-1 agonists? Tell us about the mechanism of action regarding DPP4 enzyme. Yeah.
GLP-1 agonists, like semaglutide or liraglutide, mimic the hormone GLP-1, which boosts insulin release, slows gastric emptying, and curbs appetite, leading to weight loss. They don't directly inhibit the DPP4 enzyme, which breaks down natural GLP-1. Instead, they're designed to resist DPP4 degradation, staying active longer to enhance these effects. Want details on their weight loss results or side effects?
I want to ask you about a few other drugs like Saxenda and Wegovy. What are these?
Saxenda and Wegovy are both GLP-1 agonists used for weight loss. Saxenda, liraglutide, is a daily injection that boosts insulin secretion, slows digestion, and reduces appetite, approved for adults and some teens with obesity. Wegovy, semaglutide 2-second semaglutide, is a weekly injection, similar mechanism, but more potent, often showing greater weight loss results, approved for adults and kids over 12 with obesity or weight-related conditions. Both require lifestyle changes and can cause nausea or digestive side effects. Want specifics on dosing or effectiveness?
No, I just wanted to understand how they work. Okay, can I ask you also about bariatric surgery?
Bariatric surgery, like gastric bypass or sleeve gastrectomy, reduces stomach size or reroutes digestion to limit food intake and absorption, leading to significant weight loss. It also alters gut hormones, like GLP-1, to curb appetite and improve metabolism, often helping with obesity-related conditions like diabetes. Want details on types, risks, or outcomes?
So, tell me the types of bariatric surgery.
There are three main types of bariatric surgery. Gastric bypass, RUNY, creates a small stomach pouch and reroutes the small intestine, reducing food intake and absorption. Sleeve gastrectomy removes about 80% of the stomach, leaving a tube-shaped stomach to limit food and lower hunger hormones. Adjustable gastric banding places a band around the upper stomach to create a small pouch, restricting food intake, but it's less common now. Each has different risks and weight loss outcomes. Want specifics on any of these?
So we have laparoscopy. I don't even know how to say it. Adjustable something. Sleeve gastrectomy and lap. You have to help me out with this. I don't know how to say them.
No worries. Let's clarify the terms. You're likely mixing up laparoscopy, which is a minimally invasive technique using small incisions and a camera, with the surgeries themselves. The types are 1. Adjustable gastric banding, often called lap band. A band is placed around the upper stomach to create a small pouch, limiting food intake. It's adjustable and reversible, but less used today. 2. Sleeve gastrectomy. About 80% of the stomach is removed, leaving a slim sleeve that holds less food and reduces hunger hormones. 3. Roux-en-Y gastric bypass, pronounced Roux-en-Y. A small stomach pouch is created, and the small intestine is rerouted to it, reducing food intake and nutrient absorption. Laparoscopy is just the method used for these, making them less invasive than open surgery. Want help with how any of these work or their pros and cons?
I would like to know their differences and how the names relate to the, what's going on.
All right, let's break down the differences between the three main bariatric surgeries and explain how their names tie to what's happening. 1. Adjustable gastric banding, lap band. The name comes from the adjustable silicone band placed around the upper stomach, creating a small pouch that holds less food, slowing eating and promoting fullness. Lap refers to laparoscopy, the minimally invasive technique used, and band is the device itself. It's adjustable via a port under the skin to tighten or loosen the band, and it's reversible. It's less effective for major weight loss, 10-20% of body weight, and less common now due to complications like band slippage. 2. Sleeve gastrectomy, named for the sleeve-shaped stomach left after removing about 80% of it. Gastrectomy means stomach removal, and the resulting tube-like stomach restricts food intake and cuts hunger hormones like ghrelin. It's straightforward, done laparoscopically, and leads to 25-30% weight loss. No rerouting of intestines, so fewer nutrient absorption issues. 3. Roux-en-Y gastric bypass. The name Roux-en-Y describes the Y-shaped intestinal rerouting. A small stomach pouch is created, restricting intake, and it's connected to a lower part of the small intestine, the roux limb, bypassing most of the stomach and upper intestine to reduce calorie absorption. Gastric bypass reflects skipping parts of the digestive tract. It's also laparoscopic, highly effective, 30-35% weight loss, and impacts appetite hormones but carries more risks like nutrient deficiencies. Key differences?
Okay, that's good. Question then. So, what are some things after the procedures you have to do for care? Talk to me a bit about DXA scanning too.
After bariatric surgery, post-op care is critical. You'll need to follow a staged diet, liquids, purees, then soft foods, gradually moving to solids over weeks to avoid stressing the new stomach. Lifelong habits include eating small, nutrient-dense meals, chewing thoroughly, staying hydrated, and avoiding high sugar or high-fat foods to prevent dumping syndrome or weight regain. Regular exercise, like vitamin 50 minutes weekly, supports weight maintenance. You'll take vitamin and mineral supplements daily, like B12, iron, and calcium, since nutrient absorption can drop, especially with bypass. Follow-up appointments monitor weight, nutrition, and complications like infections or hernias. Psychological support helps adjust to lifestyle changes or emotional eating triggers. DXA, dual energy X-ray absorptiometry, scanning measures body composition, fat, muscle, and bone density. Post-surgery, it's used to track fat loss, muscle retention, and bone health, as rapid weight loss can reduce bone density. Scans are typically done every 1-2 years, depending on your doctor's plan. Want more on specific supplements or DXA frequency?
Okay. Tell me, let's change topics and let's talk a bit about alcohol now. So,
All right, shifting gears to alcohol. It's a depressant that affects the brain, liver, and overall health, with impacts tied to how much and how often you drink. Moderate drinking, 1 drink daily for women, 2 for men, might have minor heart benefits, but heavy or binge drinking spikes risks for liver disease, heart issues, and cancers.
where the fuck
Want
did
to
you get these minor heart benefits?
The idea of minor heart benefits from moderate alcohol comes from studies, mainly on red wine, showing small amounts, 1 drink daily for women, 2 for men, may raise HDL, good cholesterol, and reduce blood
You
clot
can
risk.
raise HDL without risking becoming an alcoholic, though. Sorry, guys. Sorry that I'm so passionate about this subject, but I don't drink, and I've seen a lot of people waste their lives drinking. So I'm not promoting this shit. Sorry. However, I'm not saying everyone can live their own life. I'm not judging, obviously, but I'm just saying, like, yeah, like, because we hear these fucking arguments, guys, with dark chocolate and all this. Like, yeah, this is great, but let's not get confused. Like there's many ways to skin the cat, or how I like to say it, there's many ways to pet a cat. Maybe you scratch your back or the tail or whatever. Yeah, anyway, it's like you can make money by, going to the beach and trying to find pennies in the sand. You can also, learn a craft and get stable work. Anyway, okay, let's continue about alcohol. I'm drifting here. So tell us about some statistics that we might find interesting regarding alcohol consumption in Europe, in the world, in the UK.
All right, let's dive into some eye-opening stats on alcohol consumption, keeping it tight. In Europe, the WHO European region drinks the most globally, averaging 9.5 liters of pure alcohol per person, 15 plus years annually in 2020, equivalent to about 190 liters of beer or 80 liters of wine per person. Latvia tops the list at 12.1 liters, while Turkey is at 1.2 liters. The UK sits at 10.7 liters per capita in 2020, or roughly 21 units weekly, near Europe's average but high for binge drinking, with 33% of adults reporting heavy episodic drinking monthly. Globally, the Americas follow Europe at 7.5 liters per capita, while North Africa and the Middle East are near zero due to cultural restrictions. Men consume more than women across all regions, but the gender gap's narrowing, especially among young UK drinkers. Want specifics on binge drinking trends or health impacts?
Sorry, guys, my housemate stinks because we had a barbecue, so now we have to have a shower. Yeah, I'm gonna get some washing tomorrow, liquid. Anyway, let's go back to the topic. What about teenagers? When do people start drinking in the UK then?
In the UK, teenagers often start drinking around 13, 15 years old, with surveys showing about 50% of 15-year-olds having tried alcohol. Binge drinking peaks around 16, 17, with 27% of 15-year-olds reporting heavy episodic drinking in the past month, based on 2018 data. Parents or peers often supply it, despite the legal drinking age of 19 for buying alcohol. Want more on underage drinking trends